MB2s, or the second mesiobuccal canal, is probably the most missed canal in everyday clinical practice. It is one of the reasons why root canals in the first maxillary molar fails many of the times. It's not uncommon for an endodontist to see these sort of cases in everyday clinical practice where a clinician has done the root canal and the initial root canal looks pretty good, and the patient turns up at the clinic 2 or 3 years down the road, or sometimes even earlier, with pain and swelling in that particular tooth, tenderness in that particular tooth, and when one takes a cone beam CT, one finds a missed canal, an entire MB2 which is missed in the initial treatment. So this short video is my attempt to put together a series of steps or protocols which makes it easier for the clinician to go about locating the MB2 canal in everyday clinical practice. It's called MB2 Secrets Revealed. So let's first look at some routine clinical cases that we come across in everyday clinical practice. This is the first case. In this particular case, somebody had already done an endo many years ago. The reason why the patient came to the clinic in the first place was not because of any pain, but because the crown had fallen off. So what the general dentist did was the general dentist put the crown back, and as luck would have it, 2 weeks later, after cementing the crown back with a very strong resin cement, the patient came back again with acute pain. And then what we found was something like this, where there was a small bubble on the buccal surface and the patient was in discomfort. And this crown was recently cemented, so it was pretty strong. So we didn't want to remove the crown. So in this particular case, we redid the root canal through the existing crown. So you can see here, when there was a sinus tracing done through that sinus tract or the swelling on the side, it traced the mesiobuccal root. So what we did was we kept the existing crown in place, and then we made a small axis on the mesial surface to locate the MB2. And then you can see here, that's the missed MB2 canal. And then we retreated the MB1 as well. So both these canals cleaned out, and then you can see put some calcium hydroxide. And a week later, when we recalled the patient, we found that the patient came, this we can see here, that's the missed MB2, calcium hydroxide. And a week later, the patient came back and the swelling in the sinus tract completely disappeared and it had healed. The patient was comfortable. So we went ahead and we obturated the case. And then that's how the axis looks, a pretty conservative axis. And then that helped us to retain the crown. And this was the pre-op and that's the post-op. So typical classic missed MB2 case, which almost every endodontist sees virtually every single month in their clinical practice. Here's another case. You see here the previous endo and the crown done by the general dentist, and the root canal appears to be pretty good. It's not, you can't say it's a bad job. The patient came back a few years later with the pain. So when we looked at it, again, we decided to save the crown. So we made a small axis through the existing crown. That's the MB1, the filled MB1. And of course, towards the mesial surface of the filled MB1, we looked for the MB2, located the MB2, and then you can see the small axis and the MB1 and the MB2 enabling us to preserve the existing crown. And then we obturated the MB1, MB2 alone, and then seal the axis with a composite resin to preserve the crown. So that's how the post-op looked at. So this is something that almost every dentist sees in routine clinical practice. So you might ask the question, why is it that this particular canal called the MB2 is missed the majority of time? The reason is that what you see here as post-op is not the condition when a clinician treats the case. So for example, once you locate the MB1, the distal and the palatal, this is often the clinical scenario. So the MB2 is not visible easily like other canals. It's usually hidden, and the goal is to first uncover this hidden canal. So you can see here, the goal is to bring it from the image on the left, which is what you see in routine clinical practice, to this picture on the right where you uncover the hidden MB2 canal. So this is what we go through in this particular video. We're going to talk about the common position, where exactly is this MB2 present most of the time, the role of CBCT, how it helps us locating the MB2, some guidelines to locate the MB2, some clinical tips, and also show you some of the clinical cases as we explain each of these along the way. So let's look at position of the MB2. Where exactly do you find the MB2 most often in clinical practice? The most common position is what you see here. If you find the palatal canal and then you find the MB1 canal, then it's usually, we draw a line from the MB1 to the palatal, and then the MB2 is usually present mesial to that particular line. Okay. So here you see a clinical scenario where you have the MB1 and here's the palatal over here. So you draw a line from the MB1 to the palatal. and then look for it mesial to that line. So the MB2 is usually present somewhere here. So the goal is to remove this shelf of dentin, move this wall mesially to uncover the MB2. And the reason why it's present mesially, if you look at some of these cone beam CT figures that's found on the internet at this particular website, I think the clinician or the researcher who puts up these images is Marco Versiani. So if you look at rootcanalanatomy.blogspot.com, you're going to find a lot of these CT images put up by this clinician named Marco Versiani. And if you look at this scan, you can see the reason why it's so difficult to find these MB2s is, unlike the mesiobuccal, the palatal, and the distal canals, you can find the MB2s exit at an angle to the MB1. So the trick is to locate this despite this angle. You can see here, coronally, there's always an angle compared to the other canals. That's why it's not visible easily. So the goal is to move the shelf of dentin mesially using a suitable burr or ultrasonics, and then uncover the MB2, which is usually hidden underneath that wall. That's the MB2. Sometimes what we described just now is usually the most common way or the most common position or methodology to uncover the hidden MB2, but there are some cases where you can have a single orifice, that means a single mesiobuccal orifice, and in this orifice you can have a situation where it divides into MB1 and MB2. Not that common, but it can happen. So in that case, you probably will have a presentation like this, where you have 3 canals, and you can see that's the MB1, and there is no groove or anything to trace. You can see the wall is already extended till here. So in this case, there is a chance that when you put a file, it usually doesn't slide into the MB1 as you normally see. It usually goes in and creates a sort of a ledge here, and the MB1 and the MB2 are on either side of this ledge. So you put in a K file, it'll probably stop here. It'll not smoothly go into the canal. So in this case, what we do is we use an ultrasonic or a small-sized Longshank burr to widen this orifice. And once you widen the orifice, you can actually slide into the MB1 and the MB2. As you see in this particular picture, that's the MB1 and that's the MB2. But in order to instrument these 2 canals separately, you have to widen the orifice so you have enough room to visualize and instrument each of these canals separately. So that's the second most common location for the MB2. Of course, there are the odd cases where it can be found very close to the palatal canal and sometimes even on the walls of the palatal canals, but these are very, very rare. 9 times out of 10, you're going to find it either by moving the wall, as we mentioned, or occasionally in the orifice itself. And then there are always exceptions because there's always one odd case which breaks all the rules. But majority of the cases, you're going to find it in these 2 locations. As you see in the clinical case here, somebody did the endo. You can see the mesial filling appears to be short. But when we actually clean out the existing mesiobuccal canal, which is what the clinician has filled, and then widen the orifice, you find here, you can see here, that's the canal which the clinician has filled up, and that's the canal which the clinician hasn't found. So our goal is to locate those 2 canals and then fill it, and you can see the MB1 and the MB2 here. CBCT is a really important tool that we can utilize when you're looking for missed canals, and MB2 is no exception. So whenever possible, in fact, in our opinion, we should always take a CBCT in retreatment cases so we can look for missed canals. And you can see here, this is a case where all 3 canals looked really well filled, but the cone beam CT tells us that the missed canal is actually an MB2 with a separate portal of exit. And once you have this information, then you can actually treat just the missed canal and not touch any of the canals. So this is what we call image-guided treatment, where in this particular case, armed with the extra information that we get from the cone beam CT, we can make a very, very tiny axis or whatever axis is needed because we know what we're looking for in advance rather than hunting around blindly. So we make a small axis, and the goal of that axis is just to locate the MB2, which we did in this particular case. And then you can see here, that's the missed canal. And then we fill up that case alone and then close it with a composite material. So it's a very conservative way of handling this case. You can see here, this is the post-op. And if you compare the pre-op and the post-op, the only difference is we treated or retreated rather the missed canal, in this case the MB2. So that's how we can use CBCT as a tool. And in our opinion, we should always use the CBCT in virtually every single case of retreatment, and especially in cases of MB2, because it's always good to know in advance whether or not there's a missed canal before going around looking for it. So let's talk about Armamentarium. When we talk about locating MB2s, it's always good to have certain tools in our clinic. And let's look at some of these tools. First of all is the microscope. In our opinion, endodontics should always be done with a microscope, But if you don't have a microscope in your practice and you're stuck with a retreatment case, which means the case has already been treated once and you want to redo it again, it's probably a good idea to refer it to someone who has a microscope. However, if you do have a microscope, then yes, all what we discuss now will be even more relevant, because if you can't see it, you just can't do it. By the way, if you are a general dentist and someone who feels that the microscope is something very complicated, I have an online course which kind of takes you through step by step, that makes it really easy for you to incorporate the microscope in your clinical practice. The links of which are coming up here. Do have a look. You even get a free preview just to surf around and then go through the course, and you might probably change your mind about the microscope being something very, very complicated. And if you can get a microscope in your practice, then I think you can offer far more superior. It has a lot of advantages, and you should consider buying a microscope and putting it in your general practice. All right. So microscope, very important tool. The second tool which I use a lot is something called a needle burr, or the kind of burr that you use to break contacts when you're doing a crown prep, for example. I prefer this to ultrasonics because A, it's very cheap, it's very efficient. Ultrasonics are expensive, they take a little more time. So as far as I am concerned, I prefer a burr to an ultrasonics unless the access is a big problem. Okay. So the needle burr, very important tool. This video shows you how we use a needle burr. You can see here you have a missed MB2 there, and then you take that burr and then move the whole wall mesially using the burr. And we prefer to cut dry whenever possible. So you can see here, we're cutting dry and then just moving that wall mesially. You can see super fast, very efficient. And so that's why I prefer a burr. And then once you cut dry, then you can alternate this with ultrasonics in a wet mode. So use ultrasonics with water to just flush out all the debris. So you can alternate with a needle burr mounted on an electric handpiece or an air-driven handpiece, but cut dry, and then follow it up with a ultrasonic in a wet mode to flush out all the debris. And then when you use this intermittently, that is cutting dry with a high-speed handpiece, followed by flushing it out with the aerator, it helps you move that wall mesially. Okay, so I prefer this. The second tool I like to have is something called Muntz burr. This is invented by an endodontist named John Muntz. So we'll put the links for this as well in the video. If you look down, you will find the links for all of these things that I'm talking about. The advantage of using Muntz burrs is that it has a very long shank. These are micromotor burrs, so you get a lot of clearance. So you can always see what the tip of the burr is doing, unlike, say, a high-speed handpiece burr, which has certain limitations in terms of length of the burr. So you can see the Muntz burr has a very long clearance between the head of the handpiece and the tip of the burr. So you can always see what the tip of the burr is doing. Here's a video showing the Muntz burr in action. So you can see here, that's me using a Muntz burr, and you can always visualize what the tip of the burr is doing when you're working deeper in the canal, in the pulpal floor, or even in the canals for that matter. Okay, so Muntz burrs, a very good tool to have in your armamentarium. The third tool is, of course, ultrasonics. A lot of people use ultrasonics itself for removing dentin, but I usually like to use ultrasonics. What is the advantage of using ultrasonics? It's very simple. The main advantage is the access. So if you're using a micromotor, the design or the handpiece is such that the head of the handpiece and the burr are in the same plane, whereas the ultrasonic handpieces are designed in such a way that you get a lot more access and visibility. So they're much easier to use, but the disadvantage is that A, they don't cut as aggressive, and if they do cut, then they are usually diamond-coated tips, which are expensive and they wear away with time, and they are not as aggressive compared to, say, a high-speed handpiece. So for me, I would prefer a high-speed handpiece, but then there are a lot of clinicians who prefer the ultrasonics. So if you prefer the ultrasonics, by all means, use the ultrasonics. The other good tool you can have in your armamentarium is something called micro openers. These are just files attached to a handle. So many times when you work in hard-to-reach areas and you're looking at locating a missed MB2, then you want visibility. So if you're using your hand to hold a file, then the hand often blocks visibility. So if you have something called a micro opener, which is actually files attached to a handle, then your visibility and accessibility improve. So it's much easier to work when you're looking for, say, that catch or that initial entry. These days, the other option you have, micro openers are expensive. So a less expensive option is something called the Endo handle. Many companies offer this, but I think the one we prefer is from Venta Endo. Again, I'm going to put the link of all these products below the video so you can have a look. These are nothing but handles in which you can put in a file into this and then bend the file and use it like a pen. So you can show you a short video how we do this in clinical practice. So you can see that. This is just a regular hand file, K file or H file. We just put it there and then bend it and then you can use it. So that's the other tool I would recommend. And this is again how we use it. can see here. This is just a regular K file, everyday K file, which we insert into this instrument so that you can have improved access. So you can see me using that to locate the missed MB2. So that's the other tool. And then let's look at some guidelines to locate MB2. The first guideline that I would recommend is something called color variation. So if you look at the case here, we always find that the pulpal floor is usually grayish in color, whereas the monochromatic dentin or the dentinal walls that you see around this pulpal floor is whitish in color. So when we are looking for the MB2, it's usually along these grayish areas and not the whitish areas. So if you drill down these whitish areas here, it usually perforates. So we want to avoid drilling down these whitish areas and then look for the canals where these grayish areas merge with the whitish areas. So when we talk about color changes, we should also look at, say, calcified areas like this. So you can see a pulp stone here. And then if there is a pulp stone, that's the advantage of using a microscope, because you can easily tell the color differentiation between, say, a pulp stone, then the pulpal floor there, and the monochromatic dentine on the side. So we know that this glassy stuff that you see here is a pulp stone, is an attached pulp stone, and you can use ultrasonics to just, or bursts to just drill this out. And once you drill it out, many times you can see the missed MB2 there. Sometimes it's not as easy. Sometimes what happens is you don't see it evident staring at you, the MB2, but if you want to trace it, it's usually along the margins of where these darker areas meet these whiter areas. Okay, so if I'm looking for canals, you can see here, that's the distal buccal, and then if you look here, that's where the mesiobuccal. So if I'm looking for MB2s and MB3s, it's be along this area here, where the white area meets the darker area here. So you can see here, that's the MB1, the MB2, and the MB3, and this is at the junction of the darker pulpal floor and the whiter monochromatic dentine. The second guideline you can use is something known as the white line concept. So the white line is between the MB1 and where we assume the MB2 to be, there's always a white line, which is necrotic tissue. And if you trace this necrotic tissue, many times the balance or the debris accumulates in these depressions. So we can use these white lines as clues to drill down or look for the MB2. So you can see here, we've kind of moved this, drill down the entire white line, and you can see there's no white line here, but the white line kind of persists here, which means the debris kind of accumulates there. And we look around in that area, and that's where we find the second mesiobuccal canal, or the MB2. So that's the other concept we can use. The second concept is something called the red line concept. So the red line simply means that once you've located the MB1, when there is a vital MB2, it often bleeds from a designated point. So you have a case like this where the MB1 is already cleaned, and you can see here, there's something bleeding here between the palatal part, and let me just play that again for you. So you can see here, that's the MB1 somewhere here, you can shortly see that. And then that's the palatal, and between the palatal and the MB1, there is a bleeding point here. So that's usually seen in vital cases, okay? I'll show you some pictures as well so you get a better idea. So here, that's the MB1. This is the palate, and see between the MB1 and the palatal, you can see this red line here, and this is seen in vital cases. And you can use that as a clue to look for the MB2. So once you see something like this, you know that this wall needs to be moved mesially, which is what we do. We take a small needle burr, and then we move that wall mesially. And once you move this wall mesially, we uncover the MB2. So that's how we use the red line as a guide to look for the MB2, which is hidden under this mesial wall. The other clue I would suggest is something called etching to view color variation. So when you are looking for MB2s, especially in retreatment cases, what happens is you get a lot of debris on the pulpal floor. So one way to visualize the pulpal floor and clear it of debris is to use etchant. I'll use a case to demonstrate this. So you can see here, this is a maxillary first molar where the patient had an endo and crown placed many years ago, and the patient is reported with acute pain. So we took a cone beam CT and we found a missed canal here. And then what we're doing is we're making a selective axis there to keep the crown in place and look for the MB2. So here you can see here, we make the axis, and then as we look for the canal, we find the MB1 here. But in the process of looking for the MB2, the pulpal floor often becomes clogged with debris, so it's not very clear. So what we do, I like to do in these cases is apply a little bit of etchant orthophosphoric acid, which we use for acid etching for restorative procedures. I fill that pulpal floor, then scrub it with some microbrush, rinse it out. And once I do that, I find that I can easily see the color differentiation between the MB1 that you see there, then the whitish dentine on either side, and between this whitish dentine on either side, I see this dark area with a white line between. So it gives me a clue to look for the MB2 along this area. So let me blow it up for you so you can see there. That's the white lines on either side. That's the MB1. And then I need to look for the MB2 or the MB3 for that matter along this line. Okay, that's how etching really helps to highlight or make this area a little more clear. So that's what we did. So you can see here, really clear. And I look for the MB2 along this line, and that's where I found this. So that's the MB2. This is the MB1. And in this particular case, I even found an MB3. So MB1, MB2, and then that's the MB3 over there. So, and then you see MB1, MB2, MB3. Okay, and this is a good case to illustrate how we used acid etchant to visualize it a little more clear. Okay, so you can see the MB1, MB2, MB3 all obturated, and then we close this up. So that's the pre-op and this is the post-op. I hope that this short video clarifies and gives you a clear idea as to how to go about locating the MB2 in everyday clinical practice. If you'd like a detailed PDF which kind of outlines step by step on how to go about locating the MB2, which is something which you can keep on your phone or even print out and pin it next to your chair side for you to refer every time you get a missed canal or a maxillary first molar, then do fill in the email ID in the link that comes below, and I'll be happy to send you a short PDF which sends you step by step in a very simple manner on how to locate the MB2 every single time. Hey guys, Siju Jacob here. I hope you found that video useful. If you did, then please share it with your friends and colleagues who might find it useful. If you'd like to see more of these videos, then do click on that subscribe button, and I'll see you next week with another video. See you soon.